Low cholesterol is an independent predictor of a poor prognosis in heart failure. So, this is a paradox which has to be settled. Let's see, there is something known as lipotoxicity. This is an intrinsic cardiac metabolism of adult heart which depends primarily on the utilization of fatty acids for oxidative phosphorylation and generation of ATPs. So, when it comes to utilization, fatty acids are the ones which is maximally utilized by myocardium and they generate the maximum ATPs. This is in adult heart. In contrast, the fetal heart preferably uses glucose for energy generation. Now, what happens to this adult heart when it starts responses to stressors? And these stressors could be hypertrophy of the ventricle, it could be heart failure, it could be infarction. And that is the time when instead of utilization of fatty acids, the myocardium switches over to fetal metabolism. Now, this change is accompanied by altered substrate utilization and reduced myocardial production of ATP due to lower number of AT molecules generated during glycolysis compared to fatty acid oxidation. So, a fetal heart utilizes glucose, adult heart utilizes fatty acids. When the adult heart undergoes stressors, it converts its metabolism into a fetal heart, and that is the time when the number of ATPs produced is much lesser because the ATPs generated by fatty acids are higher. So far, so good. So lipids accumulate in a failing myocardium, in particular in subjects with especially diabetes and obesity with increased level of toxic intermediates leading to lipotoxicity. These toxic intermediate products may further worsen cardiac function and metabolism with development of progressive myocardial atrophy and protein breakdown. Activation of transcriptional coactivators like PPAR and transcription factors like SREBP1C might be important in molecular switches from adult to neonatal, regulating lipid accumulation and hypotoxicity. There's yet another thing. Elevated lipoprotein A levels corresponding to lipoprotein little a risk genotypes were associated with increased risk factor for heart failure consistent with causal association. So these are certain things which generated a hypothesis and a corona study was started. The problem with corona was that it was a retrospective analysis. What they did was they wanted to examine outcomes in patients with heart failure in relation to baseline LDL levels and HRCP concentrations. There was yet another aim of the study, which was the effect of statin therapy according to baseline measurements of LDL and HRCRP in patients with heart failure. Included patients of 60 years of age with NYHA class 2 to 4 and ischemic in origin. All of them were ischemic in origin. That means if they were ischemic in origin, these are the ones who would need statins for sure. Ischemic heart disease, statins, regardless of any levels, they need high dosage of statins. So, ejection fraction was close to 40% or 35% if the NYHA class 2 were there, and they were all eligible for the study. There were several exclusion criteria which included recent cardiovascular events, procedure or operations or planned procedures or operations, acute or chronic liver diseases more than 2 times the upper level of normal. Serum creatinine would have been anything lesser than 2.5, anything greater than 2.49 was considered to be an exclusion criteria. Chronic muscle disease, unexplained CK rise, 2.5 times upper limit of normal. Thyroid stimulating hormone with 2 times upper limit of normal, and any other conditions substantially reducing life expectancy were excluded. Now, the primary outcome was the composite of MACE, and which is cardiovascular mortality, non-fatal myocardial infarction or non-fatal stroke. The secondary outcomes were all-cause mortality, any cardiovascular event, total number of episodes of hospitalization, cardiovascular causes, unstable angina, worsening heart failure. These were all accounted for. Now look at this. Baseline versus 3 months of follow-up data. Everything, p-value significant, 0.001, 0.001. When it came to placebo versus rosuvastatin, the levels of CRP reduced, whether it was when CRP was less than 2 or when the CRP was more than 2. This 2 level, they have come out from Jupiter trial. Because in Jupiter, when they gave statins to rosuvastatin to people with HSCRP more than 2, they found a significant reduction in mortality and mortality, especially this was a primary prevention trial. So across the board, when the CRP was less or CRP was more, LDL came down, HDL increased, triglyceride reduced, and HSCRP, of course, had to reduce, so it did reduce. This is the follow-up. It was 30.6 or 7 months, 0.2 months were the average study. CRP more than 2, CRP lesser than 2. There was a divergent graphs. That means you expected very good results. This is the Foster-Mayer chart, which showed that the primary endpoints were better for everything which was where the HSCRP was greater than 2. Total mortality, when the CRP was greater than 2, favored rosuvastatin. The left of the bar favors placebo, right of the bar favors rosuvastatin. Coronary endpoints favors, when the CRP was greater than 2, favored coronary endpoints, hospital, heart failures, etc., etc. Everything was good. But none of these were statistically significant. In all these, the p-values, the cutoff of p-values to be significant is they should be lesser than 0.05. All had a trend towards betterment, but nothing suggested that it altered the things significantly as far as statistics is concerned. So the debate continued that for CRP, when it was greater than 2, should statins be prescribed, or when CRP was less than 2, they should not be prescribed. This is the total number of patients hospitalized, time to first, and total number of hospitalization. Unfortunately, whether it was CRP levels, cardiovascular events, worsening of heart failure, everything, the p-values were not significant at all. So, in this, the biggest flaw of this corona trial was that it was not a prospective study. It was a retrospective study. So all retrospective studies have their own fallacies, but it was something which generated a lot of hypotheses. And in this retrospective hypothesis generating study, they found a significant interaction with HSCRP and effect of rosuvastatin for most endpoints, whereby rosuvastatin's treatment was associated with better outcomes with patients of HSCRP greater than 2, but was not statistically significant. So yet another trial was considered. This is GC heart failure trial. In this, only 40% patients were of ischemic in origin. They enrolled patients more than 18 years or older with chronic heart failure, NYHA class 2 to 4, irrespective of cause and left ventricular ejection fraction. Randomly assigned them to rosuvastatin, and so there was subset was a little confounding. They had preserved ejection fraction also, they had poor ejection fraction also, they had ischemic origin and non-ischemic origin. So randomly they were assigned to rosuvastatin and placebo, and patients were followed for almost about 4 years. Two co-primary endpoints were considered, time to death and time to death or admission to hospital for cardiovascular reasons. And secondary outcomes were the conventional MACE, cardiovascular mortality, cardiovascular morbidity on admission for any reason, sudden cardiac death, admission for any reason, admission for cardiovascular reason, admission for heart failure, myocardial infarction, and or stroke. Where were we? Followed for almost 4 years. The graphs are overlapping. The confidence, the hazard ratio is very, very close to 1. Whether it was time since randomization for death or whether it was all-cause mortality or MACE, the graphs are exactly overlapping. So when you look at this, patient who died of cardiovascular reason, not significant. Sudden cardiac death, not significant. Admissions, not significant. Nothing is significant. And again, for ejection fraction less than 40%, ejection fraction more than 40%, when you compared the study, and it was not a small study, each group had 2,500 plus of patients. There was nothing significant to suggest anything. And the conclusion was that first conclusion was not prescribing statins to patients with heart failure of non-ischemic cause. This was clear. So that is, in any case, by intuitive thought and action, you would know that you don't have to prescribe statins for non-ischemic reasons, for whatever reason. Second, stopping statins in patients with heart failure of ischemic cause if the patient is convinced of the drug's futility or to avoid multiple drug use or not to worse compliance to other drugs that are proven to be effective in heart failure. So this was a very bold statement to give. So the continued confusion was even further confused by this trial in 2013 from Germany, and Kahn et al. Said that he also did a study where he said that low density lipoprotein levels in patients with acute heart failure has found that low LDL, lesser than 71 milligram percent, similar to low cholesterol, were associated with a poorer prognosis and higher overall mortality in patients with heart failure, regardless of etiology and systolic function. Now we are sure that if you reduce your LDLs to lesser than 71 milligram percent, actually you kill more in a person who has got a heart failure. So why does it happen? Because intuitively, statins reduce anti-inflammatory drug. In an ischemic heart disease, they reduce the further ischemia, progression of coronary artery disease. So why does it that people don't benefit? So several mechanisms for apparent benefit of higher total serum cholesterol levels have been proposed. And the three most popular theories are the endotoxin lipoprotein hypothesis, the coenzyme Q10, ubiquinone hypothesis, and the third one is selenoprotein hypothesis. The most favored is endotoxin lipoprotein hypothesis, and this says that patients with heart failure experience mesenteric venous and bowel wall edema because of back pressures. So the liver enlarges, JVP enlarges, and so does the venous and bowel wall edema occurs because of back pressure, which in turn causes bacterial translocation and endotoxin release into the bloodstream. Now, lipoproteins are then needed to bind endotoxin and decrease the systemic release of pro-inflammatory cytokines. The moment you reduce this lipoprotein, people start dying more because you're not able to scavenge the endotoxins. Similar theories are there for ubiquinone hypothesis, which suggests that statin use decreases the available levels of ubiquinone, which is needed for the production of ATP in order to meet the increased metabolic demands of the cells. And lastly, the selenoprotein hypothesis reasons that statins interfere with the enzymes which produces more of transport RNA and prevents its maturation to a functional transport RNA molecule. This results in a decrease in available selenoproteins, which are a necessary precursor to selenoprotein enzyme that serves a similar antioxidant role to ubiquinone. So these are three things, though not proven beyond reasonable doubt. Now, where are we as far as current recommendations are concerned? So statins are not beneficial as adjunctive therapy when prescribed solely for the diagnosis of heart failure in the absence of other indications for their use. What is the class of recommendation? Class 3. That means they are bad. They should not be given. And level of evidence is A. We are towards a very confusing story as far as heart failure and statins are concerned. We don't know that what does the recommendation mean when it says that for solely for the diagnosis of heart failure in the absence of other indications. Ischemic heart disease in itself is an indication for statins. So we are not too sure because the clarifications has to come later. Where will it come from? How will it be generated? Don't know. But these are certain subset of people, super genes. This is blood of an Italian villager. Villages may hold the key of preventing heart disease, where the average lifestyle span is greater. That everybody in the whole village, unless they die of accident, suicide, or homicide, they live to be an octogenarian. Thank you very much for your patient listening.